Hello and welcome to another episode of the BAME Health Collaborative podcast, Together We Can. I'm your host this evening, Emily Blake. Now tonight I have not one, not two, but three amazing guests joining us today. And the first guest I'd like to introduce is Helen Davenport. She is a healthcare executive for nursing quality and governance. And she is joined by Isaac Otomewo, and he is prescribing advisor specialist for the pharmaceutical management. So we've got some big titles there. Please enter the studio, Helen and Isaac.
Hello.
Welcome. Thank you so much for joining us this evening. How are you doing?
We're doing fine. Thank you. Thank you.
Lovely. And I'd also like to introduce another guest with us this evening. We have Trisha George, and she's governance lead in the NHS. So very lucky to have you, Trisha. Welcome to the show.
Hi, good evening. Thank you for having me.
You're so welcome. So we'll start off with you, Trisha, if you wouldn't mind telling us a little bit about yourself.
Okay, so my name is Trisha George. I am a registered nurse by training, but I function currently in the NHS as a governance lead in a large NHS trust here in London. I was trained here in the UK. All of my experience is within the NHS, so it's very dear to me. Yes, and I'm quite honored to have been asked to, be part of this whole initiative that is the BAME Health Collaborative.
Oh, we're very lucky to have you. Thank you. I'll be back with you in a second. Isaac and Helen. Helen, can I start with you? Would you mind just introducing yourself to our viewers, please?
Of course. Thank you, Emily. Helen Davenport. I'm a clinical quality director. Currently, I work with NHS England and NHS Improvement. My background is nursing and midwifery and clinical leadership. I've worked in the NHS for over 31 years now, and I've done much work in that time with the BAME community, both the staff and with the patients as well.
Brilliant, thank you. And Isaac, if you wouldn't mind, a little bit more about yourself, please.
Hello, thank you, yes. My name's Isaac, as you know, I'm a pharmacist. I've been a pharmacist for 27 years and I have lots of experience in medicines management. I've worked in community pharmacy, hospital pharmacy and in primary care. Currently, I'm working for a mental health trust in London and working with BAME people and their experiences has always been a really big part of what I've done, and really excited and pleased to be able to be part of the BHC.
What does it mean to you, an organisation like the BHC?
To me personally, I just thought it was really important because working in the NHS for as long as I have and some of the stuff that I've seen over the years, sometimes for various reasons, people from the BAME community get treated a little bit differently. And so for me as a pharmacist, just sometimes the experience that I have with them and talk to them about the medication and help them to feel much more assured about their medication and when to take it and how to take it. I just thought it was a really good thing that I could do.
Yeah. And Helen, how about you? What does it mean to actually have something like the BHC and also to be a part of it yourself?
It's incredibly important to have BHC. BHC is going to set precedents for the fact that there's such an incredible subscription from the membership, the trustees, and the incredible interest, not just at a local level, now it's becoming international. That is very important. What's important for me personally and both professionally, it is the right time. We've got to influence and make a change. We have got to improve the lives and the healthcare and the conditions for the staff in the NHS. So this is absolutely right, the right time. The importance of being in this organisation is very dear to me. I've worked with our chief executive. I've worked with Mukul. She's a dear colleague and a friend, and her legacy and the legacy of others is going to be historical. fantastic, absolutely fantastic, and an incredible privilege.
Oh, beautifully put. Thank you. Trisha, what does it mean to you for something like the BAME Health Collaborative to now exist? Finally, we have something like this. What does that mean to you?
It means a great deal because we're seeing more and more in healthcare, all the disparities that are coming to the fore. We knew that they were there, but, now we just cannot turn a blind eye to them. So whatever we address, as we go forward, it's not going to be short-term measures. This is going to last for a very long time. What we're looking at is, good health outcomes for people of color, Black people, Asians, once you fall into that ethnic minority grouping. So by pushing ahead, by engaging, etc., we are hoping that, years from now, everyone can look back and say, yes, this was worth doing because now we can see the benefits for people, in the future.
Mm. And what do you actually hope that we will achieve together?
Well, it's all about working collaboratively. Everybody seems to be working in silos. You're getting different outcomes, you're getting different material coming through, research findings, etc., all the products, etc. But there isn't that cohesive working together. So by engaging with, key players, with manufacturers, with pharmaceutical companies, etc., it is going to be, that outcome that we're looking for, which is great health outcomes for people. So that's what we're looking for.
Yeah. Do you have a vision for the next 5 years with the BAME Health Collaborative?
I'm hoping that, things such as, because we know we have a lot of diabetics within our ethnic minority communities. And oftentimes, the outcomes for them, they end up with amputations, they go into diabetic comas, etc., because diets are not controlled. The medication that they're using, that they're currently on, isn't as effective as it should be. So by exploring and working for, with pharmaceutical companies and so on, we can get involved in doing, active research and looking at those findings and finding modifications, to different products that are on the market, and probably even coming up with new and better, medication that will have the effect. By engaging with our communities more, then a lot of people probably will not need to be on medication, because then you're getting material and information in a language and a style that you can understand, that you can relate to, that is practical to the way that you live, to your customs, etc. So, we're doing all of that because it's not just about the clinical side of things. You're going to approach this holistically. Yes, because, a lot of people are into alternative medicine and very healthy eating. So by doing all of that in a collaborative manner with interested parties, we're hoping that, we would get that engagement. And through that engagement, you see the benefits being reaped down the line.
Brilliant, thank you. Something like diabetes, as you mentioned, I mean, do you think there's a lack of information available for BAME communities? The awareness that actually you may be more at risk. Is there enough information on that?
I'm not sure that there is enough, and probably it is possible that what is out there is not in a style, a language, a format that people can identify with. So it's looking at things like that. What do we currently have? And then getting the feedback and opinions from the people who are actually falling into that category. What are they saying? When you present them with the leaflets and so on that are currently available, do they understand what information is in those leaflets? Do they actually apply to them? Are they practical? Are they things that they can actually incorporate into their day-to-day living? So yes, it's looking at what is currently available, getting the feedback, and then making any necessary adjustments so that when they are reintroduced, you get more engagement and more compliance from the people who are affected, by things such as diabetes.
Thank you. Isaac and Helen, I'm going to come back to you now. Helen, do you think that there is enough representation in the boards? Sitting at those tables that are the decision makers. Is the representation there?
Emily, it's incredibly inequitable. It is absolutely stark. If we review just the UK alone and look to the number of acute trusts where the executive team have the membership in terms of BAME executive leaders, it's 3-4 trusts in the country. There are possibly 2 chief pharmacists, band 9 level, and it's quite shocking that there's no other way of stating it. It's I speak the truth.
Yeah, no, and it's really refreshing to hear that, Helen. Thank you for your honesty. It's something that I suspected. I was looking at one of the companies that will actually be taking out some work on contract for track and trace, and I realised that looking at that board, it was just Caucasian people. So it does lead you to wonder, how are the needs of people from other backgrounds being really truly looked after? And I think that's where BHC can really come in and make a change. Isaac, do you believe that BHC can actually help to change things like this? Because the representation isn't there, and it's obviously leading to many people not being aware of help available to them, about health conditions that they may be more prone to actually getting themselves. Do you think BHC can really help with this?
I certainly do. I mean, BHC can have a influence when they get involved with NICE, for NICE guidelines, for example. And we have the expertise out there, and we just BHC can be a platform to put people's names forward. And once people kind of see that we have a voice, and that it can be heard, then change can come. We have to start somewhere, and the time really is now. If we don't do it now, when are we going to do it? I mean, COVID-19 highlighted some of the inequalities that BAME people start, even from the healthcare workers. 60% of the healthcare workers that died were from the BAME communities, yet we only make up 20% of the workforce. Why is that? And we need to kind of, BHC can help to kind of focus the research into this, because everybody knows this, but at the minute we're not really sure as to why. Yes, they could be partly socio-economic, but it can't be the only reason. When we look at the fact that the first 10 GPs that died were all from the BAME communities. Why is this? And all these questions need to be answered. And BHC can be a voice and knocking on that door to make sure that these questions are answered. Because if we don't ask these questions, they won't be answered. They'll just be forgotten about. And so we need to and BHC can be the voice that does that, really.
Yeah, absolutely. And I mean, is there any speculation as to why we're seeing that disparity and why it's affecting people from BAME communities at all?
Well, there is some issue about it being socio-economic, and that is obviously that is absolutely true, because even when you look across the country, the areas that are much more affluent have had less deaths, and so that is one factor. There's been some talk about there was an issue about vitamin D and how that was said to help boost immune system. Obviously, people from BAME communities have low levels of vitamin D, because vitamin D is produced from sunlight, and so there was, but that's the science behind that has been inconclusive. And so at the minute we are not sure, and so this is why we need to do much more research around that, and just focus in on that, really, because we just don't know. We just don't know what the reason is.
Yeah, and that's why this is so important, isn't it? What else do you think, and Helen, I'll ask you to answer this one, what else do you think the BHC need to be focusing on in the light of COVID-19? Is there anything that you think is a really important area that we should be looking at?
We should be absolutely focused on the way in which BAME staff and patients are treated and managed. And what I mean by that is access to PPE, equitable access to support when it has been agreed through the risk assessment that it's unsafe for staff to work in a specific area. They must be supported with their redeployment, and BHC can absolutely support that.
Why do you think there was such a shortage of PPE, during this crisis? Because surely we had time to prepare.
So there was a shortage because there was inadequate preparation. I believe that's fair to say and to reflect on. And with the lessons learned exercises that have been conducted, and the urgent requirement for that supply did not happen when it should have. The preparation now is very different, with the recognition of how important that the provision of PPE staff is for all PPE equipment, for all staff, not those just working directly in a clinical setting. It is for all staff to have. And they were the mistakes, the real mistakes that were made with that first phase. When we go into the second phase, and we will most certainly, that provision and the risk assessment must be undertaken. If we reflect back, the adequate risk assessments weren't undertaken. In fact, some were never conducted at all, thus predisposing BAME staff and other staff to COVID.
Absolutely. Isaac, do you have anything to add to that at all? That was a really quite a big point Helen just made.
No, I would concur with that, really. I mean, I was working in at the time of this, and 4 members of staff at my trust subsequently died as a result of COVID-19, and that was very traumatic for me because I knew the staff members of staff personally, but we never had enough PPI at the beginning of all this, and it was very stark. And the preparations were as they should have been, and it's certainly a lot better now, and the lessons have certainly been learned, but there's still a long way to go, really. There's still a long way to go.
Yeah, absolutely. And I'm so sorry to hear of your friends and colleagues. I'm wondering, is there any support for that? Because you're working day in, day out, and then something that is this traumatic comes along. How do you deal with that? Is there extra support there for you currently? And if not, what can we do?
Oh my gosh, I work for a mental health trust, and so there was access to counselling that was put on. I guess because we were all in it together as members of staff, we kind of supported each other, and that was really how we got through it all. And that was so that's what we did as a team. But I mean, it was we just supported each other, really. On extra sets. That was what we supported each other.
With mental health specifically, do you think that there is? Do you think there's more that can be done, particularly in the BAME communities, on when we're speaking about mental health?
Yes, most when this is, and we need to kind of break that down a little bit more and look at who gets and look at that and look at I mean, it's quite simply, really. Sometimes if you're a big simple issue, are you more likely to get restricted practice? Are you more likely to get given higher doses of antipsychotics? Anecdotally, yeah, sometimes it looks as if you are, from my personal experience, but the data out there as we can. No, not really, because it isn't always clear on the form. Yes, restricted practice there, but as opposed to what the ethnic origins are of the patients that have them, it's not always there to be seen. So if that was exposure, so we could have people could see, that would be really useful, really. But at the minute, anecdotally, yes, it does look as if that is the case, which is very sad, really. And so that was why, as a pharmacist, I can get involved and say, actually, not about antipsychotics. We need to talk to patients more, find out what their issues are more, if we need to get more psychology input. But the difficulty we have in there, the lots of psychologists in the UK are white, and so therefore when they get presented with a BAME patient, and they relate to them easily, can the BAME patient get them easily? Do they so there are lots of issues to kind of face. So we could certainly be doing a lot more for the BAME communities as far as mental health is concerned.
Mm. And a final question to you, Isaac, and then I'm going to go to Trisha. What more can the pharmaceutical companies do?
Well, I mean, Trisha picked up on diabetes, and there were lots of issues with food and what patients eat, and that can blood pressure, and that can cause them to have diabetes. And sometimes when they go to the GP and they talk about food and diet, because the GP is or the dietitian, when it comes to telling them what food to eat and how to and how to do that, they just don't know what food is high in calories, what food is high in salt. They're just they cannot do that. And so there's an issue that we could do there about information about ethnic diets and good for diabetes and what isn't. As far as the pharmaceutical companies are concerned, when it comes to doing some of the clinical trials, we need to use and get more communities into those trials. The difficulties there is, though, sometimes it comes of one of trust. Some people in the BAME communities may not necessarily trust the pharmaceutical companies for whatever reason, and so BHC can do more there. To say this is an ethical company. We need more BAME people to take part in the clinical trial. So therefore, when we have outcome data and the data on the clinical trials, they were based on BAME communities as well, and not 100% Caucasian, as many of them are.
Absolutely. Thank you, Isaac. Trisha, what do you think are some of the challenges that the BHC will face in trying to accomplish some of this? Because obviously, but there's a lot we want to do. There's a lot that we need to do. What are some of those challenges, and how do you think we can overcome them?
So I think it's getting the recognition that we're a body made up of a number of professionals from different specialties across, the whole health sector that you can think of. And everyone is bringing, that expertise to the table. So it's getting that recognition. So far, we have made some very significant inroads in forming collaborations with some very known organizations. So that is something in our favor. We are getting, more and more exposure as we make communications with some very significant key players across the sector. There will always be a reluctance or some sort of misgiving, when a new organization appears on the scene. People will be curious as to know, what are you actually about? Are you just going to be, an organization that pops up today and it's gone tomorrow? Is this going to be a flash in the pan? Then you have this whole thing about established behaviors and customs that BHC will, be challenging and asking questions, and coming up with evidence to show that, well, actually, this is not exactly beneficial for this particular community of people. So can we look at, ways in which we can make a difference there? So it's combating, what comes naturally, I think, to people and established companies who have a stronghold, on a certain part of the sector. So by reaching out, having meetings, making it very clear what it is that BHC is about, and any milestone at all that we actually achieve, putting it out there so that everyone can see, this is what we have been able to achieve, and we're hoping to achieve even more.
Absolutely. It's so important to celebrate the successes, isn't it? And I know there've been a few this week, so that's absolutely brilliant. And we all need to do our best to shout out about them. And just going to move on to my final couple of questions. Over to Helen. What would you say to anyone who is considering to join us on our mission, the BAME Health Collaborative?
Oh, thank you. I was hoping you'd give me that question. What I would say, I've reflected hard about my and really how I can encourage so many more. And during that course of reflection, I very famous saying that Martin Luther King gave us. And so he told us, he said, alone cannot change the world. When I cast a stone, I cause many ripples. So the more people that we have joining and supporting, the more people that we have causing the ripples. And it's the ripples we need to cause. We need to encourage people to listen, and we need to influence, and we need to create a legacy.
Absolutely.
That's what I would say.
And thank you, Helen, and thank you for that quote. That suits perfectly with Together We Can. Isaac, what would you say to anyone listening who may be interested in helping us and joining the BHC?
To cast that stone. This is the way forward. We have to work collaboratively together, and this is the only way that we can do it. I mean, the BAME Health Collaborative is it's made up of BAME, and BAME is about so much. It's about so many different types of people. And when we cannot, we have to together. So yes, come on, join us, please.
Absolutely. Thank you so much, Helen and Isaac. And Trisha, to finish with you, what would you say to anyone who is considering, or what would you say to encourage someone who's not quite sure?
Have a look at our website, go onto Facebook, see what we have been doing. And there's also indication on there about the things that we are planning to do in the near future. This is all about all of us. We all have to be in this together in order to achieve those health outcomes that we yearn for. So it's all about just getting involved, getting in contact, getting the information, asking your questions when we have webinars, whatever, joining in, putting your voice, because you've got lived experiences that we probably don't even know about. And by sharing, you get the word out, you get that experience out there, and we take that as evidence as to why, BHC needs to keep on striving for the communities that are engaging with us.
Wonderful. Thank you so much, Trisha. Thank you for your continued support, and I hope that we'll talk again soon. Thank you very much, Isaac and Helen. It's been a pleasure, and thank you again for your continued support. Thank you so much for watching. My name's Emily Blake, and I'll see you again at the same time next week on Together We Can.